Good evening, everyone. How are you all? Welcome to First Aid AMC MCQ again. So this is our first class of 2 weeks free session, right? So again, I really appreciate that many of you joined today, and we can start with our first session, and we are going to focus on the tips and tricks of solving questions. When you start your preparation for MCQ, you will understand that like a lot of people are talking about question solve. You will get to know lots of questions people are solving everywhere. So it's a part of your preparation, and you need to know what actually this means. Because throughout the course, we are going to solve a huge amount of questions with you so that you get to understand how the questions actually come in the exam and what they actually look for, and what are the usual way of asking questions in the exam, so that you don't get confused. A lot of times it happens that you actually know the answer, but you don't know what the question is asking to you. That's why even if you know the answer, you just choose a wrong answer in the exam. And that happens a lot if you don't know what the question actually asking from you. It's not always in the exam that they will ask you the definitive investigation, or they will ask you management. Many times the exam just want to know that what will be your initial step. So it's also important to know what and how the exam questions appear and how to deal with that. Okay, we give you an idea last session that how AMC MCQ usually happens and how many questions you will have, how it usually occurs. So I gave you a little bit of idea on that. Also, we will go through a lot of this thing again in our orientation session. I know that a lot of you are already here who has enrolled into the course. So for you, this is actually your first class of your course as well. So some of you who are just doing it as a part of free 2-week session, you are actually doing our course class, because we don't repeat this class in the course. Okay. Now, tonight we are going to mainly focus on random question solvation and give you an idea that how you should read a question in the exam and what kind of different areas question can appear and what type of questions actually appear in the exam. But there is no other way that you can avoid solving questions to pass AMC MCQ. We always say that you have to have a very good idea on theory, and you use your theory knowledge to solve these questions in the exam. Now, many of you will be misguided by people who will say that you just need to solve few questions, maybe the last 3 months or 6 months, then you will pass the exam. That is absolutely a wrong way to do this exam, because many times it actually doesn't happen in that way. If maybe 1 in 100 might be that much lucky in the exam, but out of that 100, 99 usually will get a lot of new questions. That means there is nothing that you can do if you don't have enough basic knowledge on these theory topics. So that's why in our course, we focus on the both thing together. So we have our theory sessions and we have our question solve classes as well, so that you understand how the theory knowledge can be helpful for solving questions in the exam. Okay, so the idea in the course is that there are 2 kinds of question solve classes that happens. One, that we first go through the theory session, like you are going to have the cardiology session in just in a few days with me, and we will do 2 cardiology class, and after that we will do a cardiology question solve. So that's what we call as subjective question solve class. Apart from subjective question solve, we also do like a random question solvation, focusing on the recent ones. So in the random question solvation, you get 6 to 7 classes in a month just on recent question solvation as well. So it's a huge amount of question solve classes that you are going to get in the course. So if you think about 5 months, at least we can think about 35 to 40 classes on just question solvation, which is more than enough that you need. Not only that, so far we have been taking courses since I think 2018. So since 2018 or even I think 2017, yeah. So from 2017 we have all the questions solved already in your portal, which means you can get to listen to the videos of those classes. You can also see the solved questions with the answers and explanations. So in the portal, we have at least 5 years questions already available for you. So that means that if you have a good idea on the theory and you can go through those portal questions and solve it, that's more than enough to pass any exam. On the top of that, we will always also solve questions in your course as well. So that's more than enough for your MCQ preparation. Okay, so let's not talk anymore. We will give you a little bit more idea about the course at the end of this class. If you have any questions about any of the pages that we are discussing today, just feel free to ask it in the chat box. And those of you who are in Facebook, just write it in the comment section. I'll always have a look. Great. Let's start with the first question today. So a diabetic patient with ulcer on the right foot. There was some picture given. 2 deep ulcers at the medial malleolus and foot with skin necrosis and inflammation. The HbA1c is 6.5, which means the diabetes is well controlled. What's the normal value of HbA1c? Usually we want to keep it below 6.5. Okay, for diabetic patient, our idea is that diabetes is well controlled if HbA1c is between 6.5 to 7.5%. So this patient is actually well controlled diabetes. He was admitted, an antibiotic was given and taken swab and send it for culture and sensitivity. What will you do after that? You need to understand what the question asks. There are few type of questions that appear in the exam. That first I will discuss with you, then we will come back to this question solve. So in case of investigation, there is 2 type of investigation that question actually asks. One is initial and another is best. Now, many times they just don't ask what is the initial investigation. They can ask you like this, what will you do after that? So what will you do after that? That's also like a step-by-step approach, okay? So that could be your initial investigation. They can ask you, what is your next management or next investigation? You might think that they ask about management. Do I need to choose investigation or medication? Always remember, investigation is part of your management. So if they ask next management, that's also come under investigation. Okay, it depends. Do you want to start antibiotic in a patient who is having meningococcal meningitis, or you want to start first having a blood culture before starting the antibiotic? So that's a part of management as well. So a step-by-step approach. It's also investigation is included in management. That's another important thing. People get confused in the exam. So initial, next. They can also ask you, what is the next most appropriate investigation? Same thing. That means they're asking for initial investigation. So initial investigation, what will you do after that? What is your next investigation? What is your next management? What is your next most appropriate investigation? Everything means initial. Okay. Next is best. So they can ask you, what is your best investigation for this patient? That means they're asking for the confirmatory investigation. They can ask you, what is your most appropriate investigation for this patient? Same thing. What is your definitive investigation for this patient? Or what is your confirmatory investigation for this patient? So all of these are same. Okay. Did you guys get an idea that how the question can ask in the exam? That's why it is very important. Always look at the last part of the question, what actually the question asking you. That is the first thing that I always look at when reading a question, because you might read a 2-page question, and the question actually may be asking very simple thing, and that you just wasted your 2-minute time just by reading a 2-page question. So always read the last thing first, find out what they're looking for, and then start reading the question. So now this is a diabetic patient with a ulcer on the right foot, which is having skin necrosis. That means it is not a good ulcer. Ulcer associated with skin necrosis, it is a high-risk ulcer. On the top of that, diabetes can make it really worse. Okay? So you have already done the most important thing, antibiotics, swabs, culture. What are you wanting to rule out in this patient? That's the next question. What is the most important thing that will you rule out in a patient who has an ulcer like this, which is deep and causing necrosis? Osteomyelitis, right? Very good, Dr. Ali. So osteomyelitis is our main concern because deep ulcer can involve the bone and bone marrow. So they're asking what is the next investigation you want to do for such a patient. For osteomyelitis, our next investigation is X-ray. Even though X-ray might not be the best thing that we can do, but still X-ray is our next investigation. Okay, I can see some of you wanted to record this lecture. You don't need to do that by yourself. I am recording it anyway, and we will give this recording in your Facebook and YouTube. So you don't need to record this lecture, okay? So I was telling that if we suspect osteomyelitis in a patient, we should first start with the X-ray. And many times, if it is really a bad osteomyelitis, then X-ray might be able to say that there is some bony defect, there is some bony erosion on that area. And then to confirm your investigation, we do a MRI. Okay? So let's have a look. So this was the ulcer, and this is basically the ulcer which is on the foot is arterial ulcer. So it's likely chance that it's just not a diabetic ulcer, it could be a little bit of arterial ulcer as well. But our investigation remains the same. This patient is a high risk of osteomyelitis, given it's a deep ulcer causing skin necrosis already. So we divide the diabetic foot infection into mild, moderate, and severe. The mild is just local infection involving the skin, but it doesn't affect the deep tissue like our patient and doesn't have any systemic inflammatory response, like no fever, no tachycardia, nothing like that. And the erythema or redness around the wound is less than 2 centimeters. Moderate is still local infection, but the redness around the wound is more than 2 centimeters, and it can involve the deeper skin. And this is the time where we suspect deep abscess, osteomyelitis, septic arthritis, or fasciitis. Still, this patient will not have any systemic inflammatory response. That means no fever, no nausea, vomiting, or tachycardia. Severe, it's a local infection, but associated with a systemic response. Both moderate to severe, there is a risk that it can cause osteomyelitis. So this is the main thing that you need to remember for the exam. If it is a diabetic foot and it's a non-healing ulcer for 2 weeks, we are worried about osteomyelitis. Our next investigation will be X-ray foot, and then most appropriate or definitive will be MRI or bone scan. Which one is best between MRI or bone scan? Bone scan is the best. If we don't have MRI in the option, then bone scan will be our last option to choose. Okay. Now let's say it's a diabetic foot, but it's mild infection, but having a yellowish discharge from the wound. Even if you look at the question, you can see that this patient, they have taken a swab and then sent it for culture and started with antibiotic. So in case you have got a patient who has yellowish or puzzy discharge coming out of the wound, even before doing any of this X-ray MRI, we would do a wound swab first. And we send the swab for culture and microscopy and sensitivity. After that, we clean the wound. So you might need to do wound toileting or wound debridement, followed by antibiotic. Okay. And after starting the antibiotic, if you still suspect that this is osteomyelitis, you start with the X-ray foot, then go to the MRI or bone scan. So that's your step-by-step approach for diabetic foot infection. What is the choice of antibiotic for such a patient? If it's a mild infection, just oral antibiotic, you can choose amoxiclav, Keflex, or flucloxacillin or clindamycin. Usually for such cases, we will start with Fluclox or Diclox. If that doesn't help, then we can go for amoxiclav or clindamycin. Moderate, that needs IV, so IV augmentin or cefazolin, plus you also add a metronidazole. If it's a severe, then you need a triple antibiotic, so piperacillin tazobactam plus clavulanic acid or ciprofloxacin. Name of the antibiotic come in exam, so please make sure you remember it. The most common antibiotic that we use for diabetic foot is amoxiclav. That's usually the first line option that we use. Could be oral, could be IV. But sometimes if the discharge swab come back positive for a Staph aureus, then we use Fluclox. Okay? Because there could be an anaerobic infection as well in this diabetic foot patient. So that's why we add a metronidazole. So this is actually a guideline from Australia. So we say that if this is a diabetic ulcer and we are actually thinking about osteomyelitis, first line is plain X-ray. If radiographic changes compatible with osteomyelitis, if it is yes, then you don't need to do anything else. Like if the X-ray showing it's osteomyelitis, you don't need to do MRI or bone scan. The next step will be consider doing a bone biopsy and treat it as osteomyelitis. If X-ray does not show osteomyelitis, then one thing you can do is that, can you see the bone from that wound? So bone on view, or there is a thing called probe to bone. So we use it like a metallic instrument that's called probe. So if we can use that probe and we can feel the bone, that's called positive probe to bone. So if either you see bone by your naked eye, or if you use the probe and it touches the bone through the wound, there is a likely chance that it could be an osteomyelitis. Okay? Then you presume it as osteomyelitis, and in that case, you can do a bone biopsy and treat it as osteomyelitis. But I would say that if you think that there is a bone on view or positive probe to bone, better idea is to just do a MRI or bone scan to confirm the diagnosis of osteomyelitis. But let's say that even there is no bone on view or there is no positive probe to bone, but you are still suspicious of osteomyelitis, then you go for MRI. If MRI is suggestive of osteomyelitis, consider bone biopsy and treat it as osteomyelitis. If MRI not available or MRI contraindicated, then you can do a nuclear medicine scan, which is that bone scan. Okay, clear everyone? Any questions with diabetic foot? So this is how we normally solve questions. It's not just solving the questions, it's also understanding the theory. So when you get a question, you solve the question and you also read the full theory so that you get an idea about it. Okay? So no question, I guess. Moving on. A young man working came to the emergency department with big abscess under the arm. After draining the abscess, what is the investigation of choice? So you have got a patient who has, let's say, a big abscess under the arm. And you have drained the abscess, which was the first thing that we do. So incision and drainage. And after that, what are you going to do? You are going to start the patient with antibiotic, full blood count to check for leukocytosis, own culture, ultrasound of the abscess, or CT scan of the arm. Yeah, so we just seen that if we do a drainage of the abscess, because that time we should be able to get the discharge as well from the abscess. So we send the own for culture, and then after sending for culture, what are you going to do? You can start the patient with antibiotic as well. But always remember, first you take the culture and then you start the antibiotic. Why? Because if you start the antibiotic, then doing a culture doesn't mean anything. It can become false negative, because when you started the antibiotic, that antibiotic can kill the organism already. So it can be false negative in your case. So always take a culture first and then you start the antibiotic. Okay? Moving on. So this is a fluid balance chart that very commonly asked in exam. And you need to have an idea about it so that you don't get confused in the exam. So you have got a previously fit 55-year-old man who has undergone an emergency right hemicolectomy for a perforated cecal carcinoma. Okay, so it's 55-year-old perforated cecal carcinoma, had an emergency hemicolectomy. 2 days after the operation, you note that this is his fluid balance sheet. So you have given 2-liter IV fluid, but the output is nasogastric aspiration 2 liter, through the drain 700 ml, urine output 500 ml. Okay, so it's the second post-operative day. You have given 2 liter as an input. So your input is 2 liter, and you find out your output. So output, you have 2 liter plus 700 ml plus 500 ml. Along with this, we always add another extra 500 because there is some insensible loss from the skin that can be added in here as well. So always add an extra 500 for any loss that you can't measure. Okay, so if you add it, how much it comes? It's around, you can say 4 liter. Always make it whole for you for a better understanding of the math. Okay. So what you have got so far is that patient has got input of 2 liter, but output of 4 liter. So how much is the fluid deficit in this patient? 2 liter, right? So always find out, is this patient getting enough fluid, or are you giving more fluid or less fluid in this patient? So find out that first in a fluid balance chart. You can see that sodium 135, potassium is little bit low and others are good. Which of the fluid balance regimen below would you order for the next 24-hour period? So now coming to the point, any patient after post-operative, especially if they have intra-abdominal surgery, they will be nothing by mouth for a few days. So you will need to give them fluid balance, right? So you need to put them on fluid, and this fluid balance chart is very important for them. So any such patient will get a maintenance fluid like this. So everyone, they get 1 liter normal saline plus 2 liter dextrose plus 20 milli equivalent potassium per liter of fluid that you give. Okay, so that's the basic formula that you need to memorize. So this will be your maintenance for any patient. On the top of that, this patient already having a 2 liter deficit. So you need to add that 2 liter in this maintenance fluid. So where to add? That you are going to add in this normal saline. So add 2 liter here. So how much it becomes? 3 liter normal saline plus 2 liter dextrose already is fine. Now coming to this one, 20 milliequivalent potassium per liter of fluid. How much liter of fluid you are giving to this patient? 3 plus 2, right? 5 liter. So how much potassium you have to give? 20 into 5. So this 100 milliequivalent potassium. Okay. So see, this is not very hard. If you understand what you're doing, it's very simple. Any concern, anything that you did not understand from here? And that's your option D. 3 liter normal saline, 2 liter dextrose, and 100 milliequivalent. So Dr. Sanjita, or any of you who did not understand, first of all, find out the input and output. So we know that input is 2 liter, and about the output, this is 2 liter, drain loss 700 ml, urine output 500, and add another extra 500. Make it as a whole, okay? Don't make like 700 ml. Make it whole, so 4 liter. So what's the fluid deficit here? Input 2 liter, output 4. That means this patient is not getting enough fluid. And how much fluid deficit? 2 liter, okay? And after that, you find out what is the maintenance fluid. 1 liter normal saline, 2 liter dextrose, plus 20 milliequivalent potassium, every liter of fluid that you are giving to this patient, okay? So this is maintenance. This patient needs another extra 2 liter. So you add that 2 liter in here. So it becomes 3 liter normal saline, 2 liter dextrose, plus, now you know that it's 20 milliequivalent potassium every liter of fluid that you are giving. Now you are giving 5 liter fluid. So 20 into 5, that becomes 100 milliequivalent of potassium. We did count nasogastric aspirate in output. So this 700 ml, it's in the output. So this regimen will cover the next one day. That means the 24-hour. Again, after 24 hours, you will again need to reassess. Clear, everyone? Any question? And Dr. Parshad, like the reason why we are giving 5 liter is we just explained that this patient actually having 1 liter normal saline and 2 liter dextrose is the maintenance dose for every patient. This patient having another 2 liter deficit. So every patient would get 3 liter, but this patient also already having a deficit of another 2 liters. So you need to add that 2 liter, making it as a 5 liter. It's not 4 liter, okay? Moving on, a patient comes back from Thailand. Sorry, just one thing. So Dr. Hamza, because we are adding 2 liter, that was the deficit to the 1 liter. Yes, that's right. You got it right, Dr. Hamza. So next question, patient comes back from Thailand with history of having sex with multiple prostitutes. After 1 week, patient having lymphadenopathy, mild pharyngeal erythema, splenomegaly, and sore throat. Atypical lymphocytes present, monospot test negative. What is the diagnosis? Very tricky question, and this is a classic way that exam usually gives you questions. So you might be thinking one answer in your head just by reading the first line, but always make sure when you choose an answer, think as a whole, not just a single symptom, not just a single point. Always make it as a whole, read the whole question first, and then come to your diagnosis. So HIV, because patient had multiple, like having sex with multiple prostitute, that's why, or it just Epstein-Barr virus. CMV, Hep A, Ross River fever. Let's rule out the unusual first. It's unlikely to be hepatitis A because it doesn't give this kind of symptom. Ross River fever is a mosquito-borne condition in which patient says that they went to Queensland or maybe some tropical areas, or maybe bushwalking or camping, and then got some mosquito bite, and then having fever, rash, arthralgia. That's Ross River fever. So it's unlikely because nothing like that is happened here. CMV is very unusual kind of infection. Normally, patient who has organ transplant, they usually get CMV infection, especially renal transplant patient. How about HIV? HIV and EBV is the most likely differential diagnosis here. First thing, that patient went to Thailand having sex with multiple prostitutes. That's a high risk of HIV. So if you just think HIV based on this, it can become wrong sometimes. Doesn't harm you that obviously you should think about HIV possibility based on this symptom or history. But let's move on to the next. 1 week after that, lymphadenopathy, which can be found in both mild pharyngeal erythema. Now, pharyngeal erythema and sore throat is more common in Epstein-Barr virus rather than HIV. Splenomegaly, again, can be found in HIV, can be found in Epstein-Barr virus. More commonly, Epstein-Barr virus. If we look on this differential findings, that's the table 28.1 from JM, so John Murtagh, very important chart. How to differentiate between EBV and HIV. We can see that Epstein-Barr virus can be insidious and HIV can be acute onset. Fever can be found in both. Fatigue, because it's a viral infection, it will cause fatigue anyway. Now have a look to this. Tonsillar hypertrophy, tonsillar exudates, or pharyngitis, it's common in EBV, not very common in HIV. Whereas oral ulcer is common in HIV, not in EBV. Jaundice, rarely HIV. Cervical lymphadenopathy, common in both. Hepatomegaly can be found in EBV, rare in HIV. Splenomegaly 50% in EBV, rare in HIV. Atypical lymphocyte, 80 to 90% cases in EBV, and in HIV less than 50%. Now, if we come back, we can see that patient had atypical lymphocyte. Again, we can't be totally sure that is it HIV or is it something else, right? So you can also see that monospot test negative. Monospot test is a test that we do for Epstein-Barr virus, but it doesn't mean that if someone having a monospot test negative, it cannot be EBV, because it's not always that in Epstein-Barr virus patient, you will get monospot positive. So there's a 30 to 40% cases, there will be negative monospot, still it's Epstein-Barr virus infection. All right. So that's why we say that don't just focus on a single point, it's the whole point. The symptom is very important. This patient doesn't have symptoms of HIV, rather it's more common towards the EBV. Same patient, if the patient coming to you with fever, oral ulcer, then cervical lymphadenopathy, okay, then you might be thinking about HIV rather than EBV. And question actually change in the exam. So in the exam, the same question, they can totally change the symptom and the answer becomes different one. So you have to be very careful in that way as well. Move on to the next. A man coming back after a short trip from endemic area for only 5 days with severe jaundice. Also having fever. On exam, you find tender hepatomegaly, right? You do investigation, found very high ALT, AST, GGT, ALP. What is your diagnosis? So trip from endemic area coming with jaundice, fever, tender hepatomegaly, AST, ALT, GGT, ALP, everything is high. Do you think it's a viral hepatitis A, B, malaria, infectious mononucleosis, choledocholithiasis? First of all, choledocholithiasis means it's a stone in the common bile duct. It doesn't cause fever unless it's a acute cholangitis. It doesn't cause tender hepatomegaly. So it's unlikely. Infectious mononucleosis doesn't cause severe jaundice. And it doesn't cause, like hepatomegaly is not very common. And it definitively doesn't cause high ALT, ALP, GGT. It's very uncommon. A, B, C. These are the three likely chances. First of all, well, malaria can cause it. But in case of malaria, the main feature should be patient will have that kind of a fever with chills and rigor. But acute malaria, because if it is a malaria, it has to be an acute malaria. Acute malaria doesn't cause hepatomegaly or splenomegaly. Chronic malaria or long-term malaria can cause hepatosplenomegaly. So it's very unlikely that it's a malaria based on it's been just 5 days that patient having these symptoms. Okay, so forget about malaria based on that. Now, A and B, they already gave you a very good clue in here that patient is coming back after a short trip from an endemic area. So when there is a trip history, especially a travel-related history, we always think about hepatitis A, not hepatitis B. Hepatitis B is usually either it's a sexual related or blood related. So if they say that they went to the trip and had some multiple sex with prostitute, then your answer would be hepatitis B. Or they did tattooing, they did like IV needle sharing, then you can think about Hep B. But for this case, because it's a endemic area travel, patient having jaundice, fever, tender hepatomegaly, likely chance is a hepatitis A. Okay. Now, hepatitis A usually presents with initially fever, nausea, vomiting, headache, like a flu-like illness, followed by dark urine, pale stool, and you get tender hepatomegaly in this case. One of the common cause of tender hepatomegaly is viral hepatitis or liver abscess. Sometimes CCF can also cause tender hepatomegaly. Okay, we never think about malaria in case of a tender hepatomegaly. These are the three common causes of tender hepatomegaly. Just think about this if you get that. Okay. And you can see that in case of hepatitis, obviously bilirubin will be high. Alkaline phosphatase will be high, but not severely high. If alkaline phosphatase is more than 2 times normal, we mainly think about obstructive jaundice. But in case of hepatitis, AST and ALT will be very high, even more than 5 times normal. GGT can be high, but if GGT is high, we mainly think about alcoholic liver disease. Okay, so in viral hepatitis, AST, ALT is the main one that we look into, but also ALP, GGT can be high, but not severely high. Cool. Moving on to the next. You have got a patient who has parotid gland swelling, and the CT shows superficial lobe involvement only, right? No facial nerve palsy. What is your most appropriate next step? See, this is the type of question that comes in exam. So parotid gland swelling or lump, you have done a CT scan, which is usually the first thing that we do in a neck swelling. And then you got superficial lobe involvement, no facial nerve palsy. You want to do a FNAC, ultrasound, or you want to just go for total parotidectomy or superficial parotidectomy. The question is that you did a CT scan, right? Why will we do an ultrasound? No need, because you did much better investigation already. Do we want to just remove the parotid gland without even knowing what it is? No. We want to know, right? That is it a cancer? Is it a benign tumor of parotid gland? So only the way is doing a FNAC. Now for this kind of question, we will follow RSCGP guideline. So if you click on this guideline, so RSCGP is one of the commonest guideline for any medicine related topic. So whenever you want to read something, like you want to know about neck lump, so you just write in the Google neck lump or neck mass RSCGP, and these guidelines will come up. Sometimes if you don't get it in the RSCGP, just write neck lump Australian guideline and then go through the Australian guideline, because this kind of cases is different. The approach is different in USA, different in UK. So you are actually preparing yourself for AMC, and you need to read the AMC guideline or Australian guideline. Okay. So this is very recent approach to the neck mass in adult. Initial assessment. What is the red flag for head and neck cancer? Any mass that is more than 2 weeks, voice change, swallowing difficulty, ipsilateral ear pain, nasal obstruction, epistaxis, unexplained loss of weight or appetite. For head and neck cancer, smoking and alcohol is the highest risk factor. Now, obviously, you do the examinations of the neck lump, but in case of investigation, the first line investigation for all adults at risk of malignancy is doing a CT scan and a FNAC. So you will start with a CT neck and then you do a FNAC. So every time if questions come for an adult patient who is having a neck mass, you always will go for this. CT neck should be considered a first-line investigation of every patient with a neck lump and having an increased risk of malignancy. Then you do a FNAC. Other investigation is ultrasound. It is usually not recommended as a first line. Okay. When you do ultrasound, any idea, guys? When would you do ultrasound in this patient? Children, very good, Dr. Ali. Yes, in children, rather than doing a CT, we will start with an ultrasound for any neck lump. Anything else? Anyone else you want to do a ultrasound instead of CT? Pregnancy, right? Very good, Dr. Lubna, Dr. Chu. Yes, pregnancy, we try not to do that much radiation. So in pregnancy, it's not a bad idea just to do an ultrasound in these cases. And there is a lot of other ancillary investigations that you can go through. You can see that there is a flow chart given here, that step-by-step approach. You can go through that as well. Okay, so that's your neck mass guideline from RSCGP. So for such patient, we are going to do FNAC. So that's your answer. So they asked about next most appropriate step. We already did a CT scan. So the next most appropriate and also definitive is FNAC. Okay. Next, a scenario of a patient with a fall from bicycle about a week ago and also had an associated helmet fracture. Having a helmet fracture means it's a very high impact trauma, right? No confusion, no amnesia, but patient has headache, which increases with coughing. What does it mean, guys? Headache increasing with coughing? It means raised intracranial pressure. Yes, very good. That means it's a raised ICP. What is the most likely diagnosis for this patient? So, intracranial hemorrhage or intracerebral hemorrhage, subarachnoid hemorrhage, epidural hematoma, subdural hematoma, concussion. So 1 week ago, patient had a fall from a bicycle which caused helmet fracture. Now this is the main clue in here. Let's think about few other things. It can be concussion, but concussion usually should not cause this raised ICP, and there might be something else because patient having like a headache increasing with coughing still now. Okay. Now subdural epidural is our most likely cause. Subarachnoid hemorrhage usually isn't associated with trauma. Subarachnoid hemorrhage comes immediately. It doesn't wait for a week to come. Okay, so it's very unlikely to be a subarachnoid hemorrhage, and patient comes to you with a thunderclap headache. Intracranial hemorrhage, again, it should not wait for 1 week. If it is a intracerebral hemorrhage, that means it's a hemorrhagic stroke, and in 1 week, patient will come to you immediately. So it's not something inside the brain, right? So it's something which is pushing the brain, causing the raised ICP. What it can be, either it's the epidural hematoma or subdural hematoma. Now the question is, which usually causes helmet fracture, epidural or subdural? Remember, epidural hematoma needs more high impact trauma. Let's discuss this first. Epidural hematoma, a skull fracture from blunt trauma, causes laceration of arterial vessels, most commonly the middle meningeal artery. Fracture usually happens on the temporal bone. In contrast to the subdural hematoma, a tremendous force is usually required. So that's actually your main clue. Subdural hematoma, even patient can get a small injury, can end up having a subdural hematoma. Okay. Now we all know that triphagic presentation of epidural hematoma, but it's not like every patient will have this feature. So patient experience a brief loss of consciousness, followed by a lucid interval in which patient gets totally fine, and then again followed by a headache, progressive obtundation, and hemiparesis. That means initial loss of consciousness, then a lucid interval where patient gets totally fine, and then again lose consciousness. So this is actually very common in epidural hematoma. That doesn't mean that every time patient has to have this. A lot of time these things doesn't present in that patient. Okay, so don't just think that every epidural patient will have that lucid interval. And don't rule out the possibility of epidural hematoma just because you don't see lucid interval in the exam question. If you do a CT head in this patient, you will get this biconvex shaped hematoma like this. So if you get that, that's your epidural hematoma. Now look at the subdural hematoma. Epidural hematoma is the rupture of artery, whereas subdural hematoma is a rupture of breathing veins. And the veins are very easily, it can rupture, okay, because brain floats freely in CSF where the venous sinuses are fixed. So sometimes even a little bit of displacement of the brain can cause rupture of these bridging veins, causing this subdural hematoma. So you might be thinking that dura is below, like obviously first epidural, then subdural is spaced, right? So you must be thinking why the epidural hematoma needs more force than subdural. The reason is that epidural is artery and subdural is a vein. And because it's closer to the brain, any displacement of the brain can rupture these breathing veins and cause this bleeding. Okay, so presentation for subdural hematoma, sometimes patient might be totally asymptomatic. This patient also can come to you with headache, confusion, altered mental status. They can come to you with hemiparesis. But sometimes epidural hematoma comes very acutely, not as a chronic presentation. Subdural hematoma can even present weeks and months later. Okay, so in any elderly patient with a sudden change in their mental status or sudden dementia in an elderly patient, always rule out possibility of subdural hematoma, because patient might have just tripped over and just a small head injury might happen. Patient even doesn't have any pain. Still, that caused subdural hematoma, and that might be the reason patient having this sudden decline of mental status or sudden dementia or forgetfulness. Any sudden dementia in a patient, our first thing is to rule out subdural hematoma. So we do a CT head or MRI scan of the brain to rule that out. And after that, you think about some other causes of dementia. Okay. So this patient most likely having a epidural hematoma based on his helmet fracture. And subdural hematoma on the CT scan, it looks like this, it's called lucent shape. Okay, so if you get something like that, it's likely to be a subdural hematoma. Next is a parent coming to you that their son has hereditary spherocytosis. They want to know that what is the chance that his siblings will get the same disease. So this is a very common scenario in the exam, that they give you a condition which is having some hereditary inheritance, and they ask you that what will be the percentage of his siblings also getting the same condition. The first thing that we need to know in such case is that what is the hereditary inheritance for this spherocytosis. It is autosomal dominant, autosomal recessive, or X-linked recessive. Guys, yes, it's autosomal dominant. So if we know about it, it becomes very easy to answer, because we know that in autosomal dominant, how much is the chance of getting the disease in the siblings? Is it 25% of his brother, 50% of sister, 50% of brother, 0%, or 50% of brother and sister? Okay, I will come to the answer, but let's discuss this thing first. This is a very, very interesting topic. If you know it, you will never need to even memorize this thing for you. So let's discuss genetics. For genetics, the basic is always important. And if you don't know the basic, you will always memorize it and never ever even understand why I am choosing 50% in autosomal dominant. So let's say this is a male married to a female with XX. Now, for the purpose of your understanding, I am using XY and XX. It doesn't mean that this is an X-linked recessive inheritance. Okay, you can use anything, like you can use AA and BB. It's just like one is a dominant gene, another is non-dominant gene. So that's what this XY means. Okay, doesn't mean that this is a male and this is a female. It means that this is a male who has XY gene, this is a female which has XX gene. Okay, if you understand that, it becomes easy for you. If you feel confused, use AA and BB. That becomes much easy. Now, what will happen in here? We are going to get 4 different results, right? So there is a chance if this male has offspring with this female, then what are the chances? Before even doing that, let's say that this male has this gene or has this genetic defect of hereditary spherocytosis. Any autosomal dominant inheritance, only one gene needs to be affected, like only one gene needs to be affected to inherit this condition to the next generation. Okay, so we say that if one gene is affected in one patient, that's more than enough for the full-blown disease. So let's say this Y prime is that defective gene in this patient. and he has married a female who is totally normal. So the possible scenario can be XX, can be another XX, then can be Y prime X, so XY prime, can be another XY prime. Again, as said, that this doesn't mean that this is female and this is male. Don't think in that way, okay? So what you have found in here is that this is like this child is normal, this child is normal, this child has that defective gene, which means it's an affected child. This child also has this affected gene, so this is also affected. So what you have found? You have found 50% normal and 50% diseased. Remember one thing, autosomal dominant can equally affect the both male and female. So doesn't mean that 50% of brother will get it or 50% of sister will get it. 50% of brother and sister can get it. Now you might be thinking that because one son already has got it, from 50%, 25% is already gone. Is it like that? No. This is a percentage on each pregnancy the patient will have. So next pregnancy of either son or daughter will get the disease, and 50% chance that they might be normal. Same again in the next pregnancy, 50% of chance that either a son or daughter can get affected, or 50% chance that the son or daughter will be normal. So each pregnancy we're talking about, okay? Is this clear for everyone? It's not needed because it's an autosomal dominant inheritance. You don't need two genes affected for this. It's usually one gene which gets affected. Now coming to the two gene effect, you have got a patient. Again, we're talking about autosomal recessive. Okay, you have got a patient who has XY and XX. Again, this is not male and this is not female. It's not like that. It's two kind of defective gene. Now, you have got a patient who has one defective gene of thalassemia. That means, let's say the male has got one defective gene of thalassemia and the female has got another defective gene of thalassemia. So both of them is thalassemia carrier, right? So in that case, what will happen? So the possible scenario are X prime, X prime, X, X prime. Then we have got X prime Y and XY. So we have got one, that means 25% normal. We have got one defective gene here and one defective gene here, which means this 50% is carrier. And we have got two defective genes. So this is a 25%, which has thalassemia major, right? So that's what will happen in case of autosomal recessive. To get the disease, you need two defective genes. If you get only one, you become a carrier. But for autosomal dominant, even just one defective gene that's all that you need to get the full disease. Okay? Clear, everyone? So this is a very commonly asked question that they ask that what will be the chance of having a thalassemia major baby if the father and mother carries one defective gene? So 50% of chance that it will be carrier, 25% chance of thalassemia major baby, and 25% normal. And you can easily find out, let's say that someone having just thalassemia minor, a thalassemia minor male marries a normal female, then the risk is very low, right? So what will happen? So you will get XX prime, and then another XX prime, XY and XY, right? In that case, you can see 50% carrier and 50% normal. Okay, so that means if you are confused in the exam, you just use this formula and everything will become very clear in the exam. So whatever different kind of questions they ask, as long as you understand these genetics, it's not very hard. So our patient is a hereditary spherocytosis, autosomal dominant. So we know it should be 50% of his brother and sister who can get affected as well. Is it very hard, guys, the genetics? No, right. Good. Moving on to the next. You have got a nurse who suffered needle stick injury at your ward. So this is a very important question. She had previous TB vaccine 10 years ago with positive serology. No booster taken after that. And the needle stick injury, the patient was HIV negative, HBsAg positive, and Hep C virus RNA positive. If someone has got hepatitis C virus RNA positive, does it mean it's a active hepatitis C or it's a chronic hepatitis C? Guys? Active hepatitis C, okay? Because patient can have hepatitis C virus antibody positive. So if it is just antibody positive, it can be just patient, either patient has antibody against hepatitis C or patient might be a carrier of hepatitis C. So to confirm if patient is having an active Hep C, we do this Hep C virus PCR. And if it is positive, it means it's an active hepatitis C. So the patient or source, so this is the source who is having Hep C, which is an active virus, and HBsAg positive. Now HBsAg positive can be acute hepatitis B or can be also a carrier or chronic hepatitis B. So we don't know that based on what information we have been given. So we have found a needle stick injury in a nurse whose source is now possible Hep B and Hep C positive. Tricky situation, right? So do you want to give her, do you want to give her a prophylactic antiretroviral and tenofovir? HIV is negative, so we don't need to give a prophylactic of HIV. Only tenofovir, same, we don't need to do it. Repeat nurse Hep C virus RNA after 3 weeks. Check nurse Hep B antibody level. Now, you need to have a very good idea on this topic to actually answer it correctly in the exam. There is a very good guideline on health.qld.gov.au. It's the Queensland Health Guideline. It's a very good guideline we still follow in our practice. I would suggest you to read it properly from page 1 to page 28. Okay, so read it properly to get the best idea. Obviously, I would not be able to go through the whole pages. I will just show you the important ones. So in here, what is a proper exposure means? That's also written. What is a doubtful exposure and what is a non-exposure? It's also written. Then first thing that we need to know that how the injury happened we need to know how deep the needle inserted. We need to know what the patient has done so far. That means the nurse has done so far. Did she wash the area? Did she like wash with soap and water or alcohol swab? Never ever try to remove the blood. Okay, so it's not indicated that if you just press on that area and more blood will come out and then the poison will not go into your body. It's not like that. So never ever try that and choose that option in the exam. The best thing is that if we know the source, if we know the patient who is the source, then it's the best, because we can find out that if the source has any positive HIV, Hep B or Hep C. The problem becomes if it's an unknown source. But in our patient, we know the source has this virus already. So that's a good thing. We also need to know that in any case of exposure, the exposed person, in this case the nurse, should have this investigation as a baseline. So you'll need to order this HIV antibody, HIV antigen, hepatitis B virus surface antibody, hepatitis C virus antibody. So all of this has to be ordered as a baseline for every exposed patient, irrespective of their vaccination status. Doesn't mean that if the patient was vaccinated or not, we will need to do it anyway. Now, we are not discussing about the HIV today. Let's move on to Hep B and Hep C, because that's our patient positive of. So Hep B virus. First of all, we need to know that the exposed person, did she have vaccine before or not? So did she have hepatitis B vaccine? The problem with hepatitis B vaccine, over time, even if you are vaccinated, you might not have enough immunity in your body. So this patient had her last booster 10 years ago. There is a chance that her immunity might be low. So how we check the hepatitis B immunity in a patient who was vaccinated? We check their hepatitis B surface antibody level. If the hepatitis B surface antibody more than 10 or HBsAg more than 10, patient is immune. So if you have got a patient that never ever had a HBsAg more than 10, that means she is not immune. In such case, you have to do all of this. So collect the baseline blood from the patient, start the patient with post-exposure prophylaxis. We will talk about that, what kind of post-exposure prophylaxis we are talking about, especially if the source is HBsAg positive. So what we have found that we first need to know what is the immunity level of the patient, that means the victim or the exposed person. If the exposed person antibody level is less than 10 and the source having HBsAg positive, the likely chance that this patient, that means the victim, can get infected with hepatitis B virus. For such case, you will need to give them hepatitis B vaccine at that time. Okay? If previously documented HBsAg more than 10, then you don't need to do anything. So coming to the hepatitis B virus post-exposure prophylaxis. If you already know that the source is positive of hepatitis B virus, then you are supposed to give both the vaccine and immunoglobulin to the exposed person, ideally within 72 hours. Okay? Is this understandable? I know this is a little bit tricky for you and it's very confusing. I would like you to understand that first understand what is source and what is exposed. Source is the person who has this virus positive in our question. An exposed person is the nurse. Okay? And then you think who is the victim? The exposed person or the nurse, right? She has the risk of catching those blood-borne viruses. Is this clear for everyone until this? Yeah, good. Now let's think. There are few scenarios that can happen. You did the baseline blood of the exposed person. So you got an idea that what is the hepatitis B immunity of this patient. You have found that the patient previously vaccinated. So our patient is previously vaccinated and patient current hepatitis B antibody level is more than 10. So when you did the hepatitis B antibody level today, next day you have found patient have immunity against hepatitis B. If patient is immune, you don't need to do anything. So no treatment. Okay. Now, let's say current hepatitis B immunity is less than 10. But previously patient was immune to hepatitis B. Still, there is no need of any treatment. But the problem is that there was no documented history that patient hepatitis B antibody level was more than 10. These are the population we call vaccine non-responder. That means even though she had the vaccine, she did not respond to that. In that patient, you will have to give both immunoglobulin and vaccine. Is this clear for everyone? So basically think just in that way. If a patient never ever been responder to the vaccine, you will need to give immunoglobulin and vaccine. If patient was vaccine responder anytime, then no need of any treatment. That's the basic idea. Okay, a lot of things are here. You should go through that in your own time. Otherwise, I will just make you very confused. Okay. So what we have found in this patient is that the source is hepatitis B surface antigen positive. So she has a risk that she can catch the hepatitis B vaccine from this source. So for that, we don't know what is the immunity level for this patient. The best idea in this case is to check the nurse hepatitis B antibody level first to know about her immunity. If she's not immune and never ever she was immune, we can start her with vaccine and immunoglobulin. Okay, clear for everyone? Now you might be thinking, what about this hepatitis C virus? The thing is that there is no vaccine or immunoglobulin for hepatitis C virus. Only thing that you can do is that you can follow up this victim every 6 weeks. So initially 6 weeks, then 6 months. So usually we do multiple repeat hepatitis C virus antibody in the exposed person to see that if she is developing hepatitis C virus or not. You can't do any post-exposure prophylaxis because there is no vaccine available for Hep C virus. Only thing that you can do is to protect her from Hep B. Okay, move on. You have got a lady who is coming to you with weakness of lower limbs. So let's say it's a 50-year-old lady coming to you with lower limb weakness. She drags her foot while walking. Dorsiflexion, plantar flexion is weak, reflex exaggerated, but equivocal plantar response. What is the diagnosis? Cervical spine MS, MND, spinal canal stenosis, lesion in the cerebral cortex. Lesion in the cerebral cortex is not a diagnosis, but the other three can be your diagnosis. Now, 50-year-old patient coming to you with lower limb weakness. She's dragging her foot while walking. Dorsiflexion, plantar flexion is weak. So if dorsiflexion is weak, she will drag her foot because it causes foot drop, right? So you have got that. So muscle weakness, reflex is exaggerated, but plantar response is equivocal. First of all, get an idea about what is upper motor neuron and what is lower motor neuron type of palsy. We call that any kind of lesion from your cerebral cortex. So if this is your cerebral cortex, any lesion from cerebral cortex so that what I have drawn here, this is the cerebral cortex, let's assume. So this is your corticospinal tract. So from cortex is going to the spine. Any lesions from cortex to the anterior horn cell of the spinal cord, it can cause upper motor neuron type of palsy. And any lesions from anterior horn cell of the spinal cord up to the muscle or end organ, that can cause lower motor neuron type of palsy. Okay. Now the difference between these, both of them can cause muscle weakness, but upper motor neuron causes spastic paraplegia, whereas lower motor neuron causes flaccid paraplegia. Muscle tone will be increased in upper motor, will be decreased in lower motor. Reflex will be exaggerated in upper motor, will be reduced or absent in lower motor. The another thing that if you do a plantar response, which is the Babinski sign, you will get extensor response in upper motor, whereas like flexion or equivocal in lower motor. Okay, so that's your main difference between upper motor and lower motor neuron type of palsy. Now come back to this question. You have got a patient who has weakness in the lower limb. We understand that our muscle is weak, but reflex is exaggerated, which means it's upper motor neuron type of palsy. But why the equivocal plantar response, which means it's a lower motor neuron type of lesion? Now, the basic is that if you have got a patient in whose you have got both upper motor and lower motor neuron type of lesions in the same limb, that is likely to be motor neuron type of disease. Because if you get a mixed finding in a single limb, that's likely to be motor neuron disease. Okay, and that is the commonest form of motor neuron disease. So this is our diagnosis for this case. Now you might be thinking why it's not cervical spine MS. If it is a multiple sclerosis, you should get only upper motor neuron type of palsy. And in this case, you can see that there is no sensory loss in this patient because it's motor neuron disease. It's only affect the motor neuron, not the sensory neurons. In MS, you get lots of sensory disturbance as well. Okay, so that's why it's not MS. Why it's not a spinal canal stenosis? Spinal canal stenosis, again, it gives upper motor neuron type of palsy distal to the canal stenosis. So if it's a cervical spinal canal stenosis, then the whole upper limb and lower limb should have just upper motor neuron type of palsy. So that's why we are ruling out option A and C, and the most likely answer is motor neuron disease. Okay, is this clear for everyone? I know it's quite tricky for you, but did you guys get the idea? And yes, it's also very important that if it is a cervical spine MS, it should affect the upper limb as well, but it's only affected the lower limb. Good. The same question, okay, a 58-year-old man dragging his left foot, reflex on the left lower limb is increased, plantar flexion, dorsiflexion is weak, equivocal plantar reflex, upper limb and face is normal. What is the site of lesion? Common peroneal nerve, cervical spinal cord, L5S1 nerve root lesion, cerebral cortex or brainstem. No, it's the same thing. It's a motor neuron disease, right? So where is the site of motor neuron disease? Common peroneal nerve is a peripheral nerve. So it's not motor neuron disease, okay? And again, the main thing is that this patient having some exaggerated reflex as well. So it cannot be just peripheral area. It should come from the upper area, right? So not common peroneal nerve. If it's a cervical spinal cord, then upper limb should be affected. So it's not that. L5S1 nerve root, again, L5S1 nerve root doesn't affect any reflex, but this is affecting the reflex. Brainstem, if it was the brainstem, you would get brainstem symptom like diplopia, vertigo, nystagmus, then hoarseness of voice. So all of those features should be there. Nothing is here. So the likely lesion site is cerebral cortex because that's usually the site of motor neurons. Okay, and on the top of that, you are getting upper motor neuron type of lesions as well in this picture. So the likely area of lesion is in the cerebral cortex. Now you might be asking, you should ask me, if it is cerebral cortex, why not upper limb and face is affected? Because it depends on which part of cerebral cortex is affected. This is called homunculus. Your cerebral cortex, different part of it helps with different part of your body. Like this part of the cerebral cortex, it mainly control your face. This part control your arm. This part control your leg. So if someone has got lesions just in this part, it will not affect any other, just the lower limb. Okay, so that's what we are talking about in here. Is this understandable for everyone? Now, let me ask you two more questions from motor neuron disease. If you get such a patient in the exam, like this patient, what will be your next investigation? And what will be your most appropriate investigation? Okay, this is the confusing part. The next investigation is MRI. The reason behind is that MRI will be able to rule out any other similar causes. So MRI cannot confirm motor neuron disease. Okay, so MRI is mainly to rule out any other similar causes which can present exactly in the same way. So that will be our initial investigation. And then the most appropriate should be electromyogram, which should be able to confirm the nerve conduction on different part of the limbs. Let's see if we can go through this guideline. So this is the RSCGP motor neuron disease guideline. Go through that in your own time as well. Give it a read. You can see that disorders that can mimic motor neuron disease. So all of this can mimic motor neuron disease. That's why we are trying to do MRI to rule this out. So there is currently no test for MND. It remains a diagnosis of exclusion. So an accurate clinical history combined with basic screening blood investigation and structural imaging of the brain and spinal cord to exclude differential diagnosis remain the mainstay of investigation. Importantly, disorders that may mimic MND should be excluded. Neurophysiological studies are the most critical in the investigation of MND. That neurophysiological study is the EMG or nerve conduction study. Okay, so first thing that we are going to do is MRI spine, and the confirmatory we can add a EMG or nerve conduction study. Clear? Okay, so that's this. Let's take a 5-minute break, guys. Let's give your brain a little bit time to adjust with lots of questions like this, and then we restart again. Are you guys enjoying the session so far? It will be really hard for you initially because we have never done any theory or anything with you. But still, you are doing good. I can see most of you are answering correctly. So that's a very good sign. But once we do a lot of theory in the class, these questions become nothing. You easily can catch and you easily can diagnose the conditions. Okay. All right. Let's take a 5-minute break now, and then we start with some other questions. Thank you all. All right, everybody, let's start again. Next question. So you have got a child who is 5-year-old and 2 tiny magnet aspirated who came to the ED after 4 hours. Okay, so 5-year-old came to ED after aspirating 2 tiny magnets. You did an immediate X-ray and you found that the magnet is in a small intestine. 6 hours after, you have done another X-ray, which shows the magnet is still in the same position. What would you do next? Do you want to do immediate laxatives, immediate surgery, do nothing, serial X-ray, or immediate endoscopic removal? Interesting question, right? I can see it like everything is your answer, A, B, D, right? Okay, let's have a look and we discuss this first, and then you come to your option again. So any swallowing foreign objects, these are the high risk foreign objects that we need to be careful of. So any button batteries, large object which is more than 6 centimeter long or wider than 2.5 centimeter, especially magnet, and especially more than one magnet like this patient, any lead based object, or previous abdominal surgery or patient who has tracheoesophageal fistula. Now, you have got a patient who you have done a witnessed magnet injection, so parents witnessed it, or in the X-ray, you have found a foreign body which looks like a magnet. You look at if the child is symptomatic or asymptomatic. If it is symptomatic child, like having abdominal pain, vomiting, diarrhea, then patient needs immediate removal. So the removal can be either through endoscopy or surgery. Okay? If it is asymptomatic, is it a single piece or multiple piece? That's the next question. If it is a single piece, you can do observation in the outpatient with serial X-ray daily. And you can confirm the passage of magnet by X-ray. If it is confirmed, then you can discharge the patient. So serial X-ray daily, and at one point X-ray will show there is no more foreign objects, then you can discharge the patient. But you have done an X-ray, and after 24 hours, no progression of the objects, then consider there is a chance that it could be more than one piece. Do a lateral X-ray. If it is more than one piece, then you need to remove it. If it is a multiple piece, so same over here, right? Serial X-ray every 4 to 6 hours. No progression on X-ray for 4 to 6 hours, needs removal. That means single piece, you can do serial X-ray every 24 hours. In 24 hours, no progression, then you are worried. Multiple piece, every 4 to 6 hours, you do X-ray, no progression, you need to remove it. Symptomatic, you need to remove it. That's one guideline. The other guideline is about when normally we do surgery and endoscopy. So we have got a multiple magnet digestion or suspected digestion, and you have done abdomen and chest X-ray which shows multiple magnet. If the magnet is within esophagus and stomach, then you can go for endoscopic removal. If it is a successful removal, then you can discharge. Unsuccessful removal, or during endoscopy, you have seen perforation of the gut or perforation of the stomach or anything like that, surgery. Basically, you need to remember, if the object is still within a stomach, then endoscopy is your first choice. Beyond the stomach, usually, if it is beyond the stomach, if the patient is symptomatic, surgery. And again, if the option comes to removal, let's say no progression on the X-ray for 4 to 6 hours, surgery will be the choice. So that means when it comes to the intestine, surgery is the choice. So our patient, we can see that it's in the small intestine, which means we need to go for immediate surgery, because in 6 hours, there was no progression. Right? Clear, everyone? Good. Move on. Now we are doing a very important. If it's in a stomach, Dr. Kupra, then endoscopic removal will be the choice. So now we are going to do a very important chart called 5-yearly CVD assessment chart. Time to time, I will always talk to you about some questions which are mastery questions. We suppose that this might be one of those mastery questions, which means that it's a very important topic and they don't want you to miss it. And those have high marks in the exam. Okay, so we're doing the CVD risk assessment. Before that, let's answer Dr. Hamza's question. We mentioned one X-ray every 24 hours. That was for a single piece. This patient has got 2 magnets, so that will not be applicable for that patient. For multiple magnet, every 4 to 6 hourly, we do the serial X-ray. Okay, good. So now we are moving on to CVD risk assessment chart. So this is the chart that will be given in the exam, and then they will give you every information that you need, and they ask you what is the risk of this patient. CVD risk assessment is a very commonly chart we use in Australia, especially to find out how risky is this patient to have a cardiovascular event in the next 5 years. Okay, so very good thing to be done. Now in the exam, this chart might be given, and you can see that in the chart, there are a few things. One, this side is for women, this side for men. And then in men and women, there is a age also here. And there is a division for a smoker and non-smoker. You can see the X and Y axis. In the X axis, you can see cholesterol and HDL ratio. And in the Y axis, you see the systolic blood pressure. That means you need this information for this chart. Now go back to the question. It's a 64-year-old smoker woman. So let's find out. This is a smoker. And so this is the women. So we are looking into this part, right? And a smoker. So this side, 64. That means we are mainly focusing on this box, nothing else. So first find out which box you are looking at. And then you would say systolic blood pressure is 135. So that you need. And you have a cholesterol HDL ratio of 6.6 by 1, right? So you have got 135 systolic blood pressure and cholesterol HDL ratio 6.6 by 1. Given that, then we need to find out. First thing you need to understand that this is the most confusing part is systolic blood pressure. So you can see over here that this is a box. Then there is another box, right? alongside this box, you can see this number 120, 40, 60, 79. What does this mean? It doesn't mean that the highest limit of this box is 120. It doesn't mean that. So what's the highest number you can put in this box? We say that up to 139 you can put in this box. Yes, notionally, very good. So what will be for this box? Up to 159. Okay. So this is how we go one by one. Just hang on a second. We will just open this essay heart first so that you can actually read that part. So this is the guideline I was talking about. And this is actually the chart. And in the chart, you can see that they have given you what does this red, yellow, blue, and green means. So this you don't need to memorize. They will give you in the exam. Okay. Now, coming back, this box that we are talking about is, sorry, it was not actually 139. That's up to 130. Okay, so add 10 from 120. So up to 130, you can put any number over this box. 150 on this box, then 170 in this box. Okay, not, you don't add 20, you just add 10. Okay, so don't get confused again. So for this box, up to 130, for this box 150, for this box 170. So that will be your number that you can put in. Once you have known about the systolic blood pressure, then come back to this total cholesterol and HDL ratio. You can see the number 4, 5, 6, 7, 8. Now, you know that this is one box, right? And then there is next box. So how much you can put in this box? Not 4, up to 4.5. Okay, then this one 5.5, 6.5, 7.5, 8.5. Is this understandable for everyone? And this is actually what is written in the guideline that I have just opened. I'll show you. Now that we know the number that we can put in this box, then we use this two number, which becomes very easy. So 135, where did you put 135 in here? So we know that up to 130 is this box, right? So 135 will be this box. That means the second box from the bottom. Then we find out 6.6. So we know that up to 5.5 is here. 6.5 is here. So from 6.6, it will be in this box, right? So we move up. So that's our patient, right? So what's the yellow box means? We can see the yellow box means this patient having 16 to 19% risk, which means this is a high risk criteria. They can ask you a few things. Either they can ask you high risk or they can ask you what is the percentage of risk in this patient. Most likely they will ask the percentage. Is this clear for everyone? And I wanted you to know that you can see that, for example, lower left cell. So they're talking about lower left cell contains all non-smokers without diabetes. So let's say this one they are talking about. Aged 35 to 44. So this side. And who has a total cholesterol HDL ratio less than 4.5? So they say that this box have a total cholesterol less than 4.5 and systolic blood pressure less than 130. So that's what I said. Up to 130 you can put in this box, and up to 4.5 cholesterol you can put in this box. Now, the next problem, if it is a marginal one, that means if you get, let's say they give you systolic blood pressure of 130, that's a marginal. If it is a marginal, you always choose the next box. Okay? So if it is 130, still you will put it in this box. So any marginal value goes to the next box. Yeah, so chart will be given in the exam, and the percentage also will be given in the exam with it. You don't need to memorize that. Everyone clear with this chart? Very good. So this was the guideline that we talked about. So you can go through this guideline, which is the SA Heart. This is South Australia Heart Guideline. Very important chart for your exam. Now, next one. Now we are discussing some nerve-related disorder that's very commonly asked in exam. And it's very complicated as well. So you've got a patient who has sustained a stab wound to the back of her left forearm in a pub brawl. So back of her left forearm. So this is the right forearm, this is the left, right? He is trying to straight his fingers on command, but you can see that on the right side, he is able to extend the finger, but on the left side, he's not able to extend the finger, but he's able to extend the wrist. So there is no wrist drop, but there is finger drop. Which one of the following nerve is most likely to have been injured? Median nerve, ulnar nerve, radial nerve, posterior interosseous nerve, or anterior interosseous nerve? Now, let's have a discussion on radial nerve first. So there are three nerves or peripheral nerves which supplies your hand: median nerve, ulnar nerve, and radial nerve. Radial nerve supplies the dorsal aspect of your hand, okay? And the palmar aspect is supplied by median and ulnar nerve. So this patient actually has the injury to the dorsal aspect of your hand. So even by looking at this, you understand that if there is something injured, it should be a radial nerve or its branch. So that's the first thing that should come into your head when you get such an injury. Then you look for, so this is your radial nerve, which comes from the brachial plexus, and then around the spiral groove of humerus, it actually winds forward at the elbow joint, and it divides into two branches. One is called posterior interosseous nerve, and another is which goes more distally, which is called superficial radial nerve. So posterior interosseous nerve and superficial radial nerve, these are the two branches of radial nerve which mainly got divided around the elbow joint. Now let's have a look at what are the presentation of radial nerve injury in different areas of its territory. Like if it is injured in the axilla, if it is injured in the elbow, what will be the presentation? Let's say a radial nerve got injured at the axilla. First of all, get an idea that what's the main function of radial nerve in terms of its motor function and sensory function. Motor means the muscle power and everything, and sensory means sensation, you understand. So radial nerve is supposed to cause extension of the forearm. It also helps with supination, And most importantly, it helps with extension of the wrist and the fingers. Okay. Now, about the sensation of radial nerve, you know that radial nerve supplies the dorsal aspect of your hand. So 3.5 finger, so thumb, index finger, middle finger, so up to this, actually the picture is wrong. So 3.5 finger dorsally will be supplied by the radial nerve. Just the same thing, so the palmar aspect of thumb, index finger, middle finger, half of ring finger is supplied by median nerve. So the dorsal aspect of this 3.5 finger will be supplied by radial nerve. So if radial nerve is injured, sensory loss can be there in this part of the hand. Okay. Now that you know the motor function and sensory function, let's say what will happen if the injury happens just at the base of the radial nerve, which is the axilla. So let's have a look. So if there is an injury on this part, that means that every function of the radial nerve will be lost, right? So that means all the motor function, so loss of extension of the forearm, loss of supination, and also loss of extension of the finger and wrist will be lost. Patient will have both wrist drop and finger drop. And there will be loss of sensation on the forearm. There will be loss of sensation on the 3.5 fingers. Okay. Now let's say the injury is just below the elbow. So if we say here, just over this area. That's likely to injure the posterior interosseous nerve. Okay. Now, if the injury is on the posterior nerve, remember it is an entirely motor nerve. It doesn't give any sensory branch. So there will be no sensory loss in this case. The only finding in case of posterior interosseous nerve injury is that patient will have loss of extension of finger, which means it will have a finger drop. Okay, that means posterior interosseous nerve helps with finger extension only, nothing else. How about injury at the distal forearm? Distal forearm injury can be due to anything like laceration, stabbing, and distal forearm injury can injure the superficial branch of the radial nerve. Now, this is an entirely sensory nerve. There is no motor function. The only sign in here will be loss of sensory function on the 3.5 finger. Very easy, right? So you know the radial nerve function as a whole, and you know that interosseous nerve is entirely motor, and the superficial branch is entirely sensory. S for sensory, right? So superficial has S and this has S, right? Easily you can remember in that way. Now that you know about it, what will be your answer in this case? This patient has a stab wound on the back of the forearm. Now the patient can do wrist extension but cannot do finger extension. So if it was a radial nerve, then patient also should have a wrist drop. So it's not radial nerve. It's likely to be just a posterior interosseous nerve because that gives finger drop. Okay, so that's how usually you can get an idea. If you don't know about it, there is no way you will be able to answer it in the exam. What is this anterior interosseous nerve? This is actually the branch of median nerve. Okay, so that's the radial nerve injury at different level. Very important. If this comes in exam and you get it right, this question always carries high mark in the exam. Okay, so that will be it for tonight, guys. There's a lot to discuss, but we usually do like this. So 2 hours is more than enough for your brain to catch information. And after 2 hours, usually we find that you don't even listen what I say. So that should be fine for today. Okay, and then we can finish the other questions in any time in our course. It should be all good. All right, so that was just one part of a question solve class. This is how usually we take your question solve class every week. And also you will get to understand how the theory sessions usually we take on Sunday, right? So usually on Sunday you have another class with me, and then we can go through that. There will be few other classes on question solve as well, taken by our other mentors. So Dr. Rabia and Dr. Uruz also takes question solve classes. So you will also get to know their teaching style in the next 2-week session. The class schedule has been given in your Facebook group. So it's the First Aid AMC MCQ, which has all the lecture schedule. Let me just open the Facebook for you so that I can show you where to look at. So if you are a member of this First Aid AMC MCQ group, everything is in here. So you can see that especially on the featured section of the group, you should be able to get every important information. And because we are taking 2 weeks free session, every day you get our schedules. We always update you that when it will be your class and everything. So you can always get to know from these areas. So the class schedule has been given in here. So if you go a little bit like this, so that's the class schedule. You can see that 2nd May was today. Then there will be another class on 7th May, then 9th of May, 10th May, 13th and 14th. Okay, so just remember that for 10th May and 13th May, these are the 2 question solve class. There will be new Zoom ID, not this ID will be given. So we will update the Zoom ID for these 2 classes. All other classes with me, the ID is same for tonight. So it's the same ID that we are going to use. Okay, now you must have an idea about how our course work. Just to give you a basic idea that how this course is going to work, let me just discuss from here. So you must have seen everything in your Facebook group, but we already know that the new batch has been started. We took a trial class on 16th April. The recording is already given in your Facebook group and also in YouTube. This is the 2-week sessions now ongoing. The course summary is, in a nutshell, we do full theory based on the guidelines that you need for exam. 5-year question solve discussion with monthly updates. So we have 6 to 7 classes in a month on just question solvation. Software-based mock tests. So you have a whole range of mock tests on everything that we are discussing with you. You get QBank, access to the course until you pass. You even get recording with extended recording access even after the finishing of the course, which you don't get anywhere. You can also claim CPD hours, especially on my classes, if you are a member of RSCGP or ACRA. We know about the cost is $499 Australian dollar. The course duration is 5 months with 3 classes in a week. Currently, we are taking it on Saturday, Sunday, and Tuesday. If sometimes there might be 4 classes in a week, in that case, we will give you the schedule about that. Every class will be on Zoom, not on Facebook after this 2-week session. And the time is usually from 8 to 10 p.m. Sydney time. We cover everything that you need for your exam preparation, extra that you need, apart from some question solvation that everyone usually does in our forum and also in our Telegram group. But there is also important idea that you should have some study partner with who you do the question solvation. that should be arranged. We also help you to find one in the course if you don't have anyone still now. So the theory that we cover is from all the recent guidelines, especially on JM, Kaplan Step to CK, and some other Australian guidelines. We discuss the theory as subject-wise, like medicine, surgery, orthopedics in that way. Medicine, we divide into case by case, like cardiology, respiratory, gastro in that way, because it's a huge amount of topic. After doing every theory classes, we do a subjective question solve class, which you will get one cardiology question solve with us. After you do that, you can also go to our portal and then can have a theory mock test. So you did a cardiology and then you can do a cardiology mock test and find out how much your preparation is. The question solvation we have from 2018 to 2023 with a monthly update. So everything, even the recording of those classes are given in your portal. So you can always go through that in your own time. And obviously we do the recent question solvation as well. The software has a huge amount of mock test for you to try and get to understand how AMC exam usually works. So we have divided into subjective mock test. We have some sample question, like monthly question solve that you are doing with our mentors. You can also do some mock test as well. And we have, right now we have 3 full mock tests in the software, but we are also trying to add another 2. So you will get at least 5 full mock tests. QBank free of charge, extra classes on ECG, CT scan, other imaging, CTG, stat, ethics, fundoscopy, and ABG. Okay. And also we know about, like, you get class recordings, notes, everything will be given. And also we provide all the books that you need for your preparation. That's pretty much everything that you actually need to know about this course. You can also go to our website in this one, and you can subscribe from website as well. If you have difficulty with that, you can reach us. You can send an email in here, or even inbox in my messenger, and we can always send you an inbox in that case. So we can send you an invoice if you have trouble to subscribe through our website. Okay, so that's pretty much everything that you need to know from the course. Any question, guys? So how to become a member, CL, I'm not sure what's your full name. So as I say, that to be a member of the course, you can just inbox us, or you can send an email. If you want to become a member of RSCGP or ACRAM, you will need to go to their website. Notionally, where I can find UWorld Psychiatry. Now, not in our First Aid AMC MCQ group. We usually give all the books in our course group. So once you're part of the course, we will give you all the access to the notes and books. So it's already be given to our course student in the Facebook group. So cardiology, no, question solve 2 is not based on cardiology 1. It's a random one. Same with question solve 1, that's a random one. Software doesn't support iPad, but it support every other device. So because iPad is a kind of mobile device, so any mobile or iPad, no software usually works in the best way, because we normally try to make sure that you are using a laptop, because this will give you the exam like experience. In exam, you will also need to appear on a desktop. So we advise you always to make sure that you have either you can use it on MacBook, or you can use it in laptop or desktop. So who has been already subscribed? Yes, we have already added everyone to the Facebook group and also to the portal. Dr. Ju Walls. So if you haven't been if you haven't got the access yet, please reach to us. So send me an inbox today and I can have a look what happened with that. Yes, the theory that we cover, that should be enough for the exam. We do an extensive theory class. There is nothing else you need to do apart from that. It's a good question. I'm not sure what's your name. Your name is coming as Vivo. So if I want to give exam in October, is it possible to finish 5 months course? Because our course will be finished at the end of September. I would say that we always say at least keep 1 to 2 months after the finishing of the course to revise everything. But if you are very good when you are doing the course, it should be enough for you. But you have to prepare yourself within 5 months. If you get in, if any of you has got a placement, especially before we finish your course, we will be able to give you access to the previous batch recording. So if you have got an exam date in July, August, even on September, we can give you access to our previous batch recording, and you can finish everything in your own pace, as well as join the live sessions in your own time. Okay, so that we offer to everyone, because it's a 5 months course. We do understand that sometimes you might be already getting a placement in your exam. So in that case, a lot of our students, they get the previous batch recordings, they go through everything in their own pace, and they just join the live session as they like. There is no recall course. The question solve class is just for our course student. The next batch will be in October. Yes, Dr. Vinod, we do the question solvations. Yeah, it should be enough for your exam preparation. Okay, so that should be it for tonight, guys. It was very nice to see a lot of you. We didn't realize that there will be 100 students in the class, but it was good to see. But just one thing we want you to understand, that these 2-week sessions are designed in a way so that you understand how we take classes. There is no hide and seek in here. A lot of course might just offer you 1 or 2 class, and that might not be enough for you to understand about that course, because anyone can take 1 class, which might be very good. But if someone can take 2 weeks class, and if you like everything, then that means that it will be a satisfactory course for you. So we give you that idea so that you get to understand about us. And only if you really feel that this course is going to be helpful, then you join us. Okay? So I would always advise that there's a lot of things going on. We get a lot of students from a lot of other course, but they fail 3-4 times, and then they come to us, and the next time we see that they pass the exam. So it happened a lot. But we always advise you, when you search for a course, when you search for something that you need help, find out in this way. At least do few classes so that you get the idea about them, and then join. Okay? Hopefully you will not get disappointed in the course. And we just finished our recent course as well. You can see a lot of reviews from our course students, and that should be enough for your idea as well. Okay, all good then. So we'll finish it here tonight. We will see you again as the scheduled classes are given in your Facebook. Thank you, everyone. Have a good night. Take care. Bye.